this station we're talking about UBT, which is uterine balloon tamponade. Okay, this is one of the techniques that we use while we are trying to help our mother who is going through, who is having PPH. So just because UBT is a management of PPH, we will recap a little bit on PPH. Okay, but I won't be talking. You're going to be assisting me so that we can do a recap and then we can get to the UBT. So we said, what is PPH? Postpartum hemorrhage. How do we quantify the amount of bleeding? When does it qualify to be PPH? 500 mils when the mother has delivered through SPD. Yeah, and then via CS is how many mils? 1,000 mils. Okay. Once you're called to a patient that is having PPH, what do you do first? You said? Safety first. Safety first, yeah? Yes. So you make sure that you have worn your protective gear. You have hopefully you assigned roles in the morning when you started your shift, yeah? So everyone just came and knew where they are going to be. True. Yeah, so the next thing? So you quickly assess your patient's airway, breathing, circulation. Sawa. Intervene. Okay. I know we have been going through the stations for airway, all those, yeah? So when we say we make sure that the airway is patent, we all understand it, yeah? So we make sure our airway is patent, we make sure that the patient is able to breathe adequately. Sindio? Yes. And adequately is meaning if their SpO2s are low, you need to support it. If they need oxygen, we need to support that, yeah? Okay, so our ABCs are okay. Our AB are okay. Then we go to circulation, huh? Yeah. Okay, so circulation, what do we do? We want to fix 2 light bulb cannulas as we collect samples. Okay. We put the patient on the monitor, we check our BPs. You have said a lot. I want you to speak up a little bit and then say them.
In our circulation, first and foremost, we want to access our IV cannulas. IV lines. As we collect our sample for GXM.
Collect sample for GXM.
Full hemogram and UECs.
Full hemogram and UECs, yes.
Blood sugar, that point as well.
Yes. And RBS, yes, thank you. Yeah. And then we want coagulation profile, thank you. What else do we want to do at sea?
I think at that point you can put the normal saline.
IV fluids, we can give IV fluids. What else do we do?
Catheterization.
Catheterization, yes. Another thing? Monitors, yeah? So if you see there, we have written ABC and vomit, yeah? Vomit is vitals, oxygen monitor, IV access, and then now we go to treatment, yeah? Okay, so we make sure that they have monitors, then we start, okay? So after that, we have taken our samples, and but the patient is still bleeding, yeah? So another C is making sure that you stop bleeding. Yeah. True. So we want to stop the bleeding. So what do?
We can massage the uterus.
We massage the uterus, yes.
We bring in tranexamic acid.
So normally what I say is do the most simplest maneuvers first, as you anticipate the others, yeah? So once you're at, let me move my patient. So this is my patient who is bleeding, and I have gotten to the uterus. I'm massaging the uterus. The simplest thing next is to take my bladder, my catheter, and put it and empty the fluid. I don't even have to catheterize the patient if I don't need monitoring, yeah? I just want to empty the bladder for the time being, yeah? After I have emptied the bladder, the next thing I will do is definitely I will be telling my assistant, put oxytocin if my uterus is still bogus, give tranexamic acid, maybe give me misoprostol, I put Parecto. Okay, and then now you examine for tears and tissue. I can instruct my other assistant over there, examine the placenta. True? Okay. Placenta is out. And if our mother is still bleeding, the next thing, I have taken my bedside clotting test. That is another one you take when you're taking sample. It is sitting there so that in 20 minutes I can be able to check and see if there is clotting. But our patient is still bleeding. We've done everything. Now I've done by manual compression. I'm waiting now to put a UBT. True. That's where we are at, and we come to our topic for today. So UBT is quite simple, and all you need is a catheter, condoms that are available in all government hospitals. True. Cord clamps, long clamps like this, and a suture. So good. So, but I'm not going to take this one. I'm going to use that. Okay. So, how you prepare it? So, you take your catheter. Normally, the catheter has the inlet and the outlet. Okay. So, you balloon on the inlet. Okay. But this ballooning is not the one that we do for when you're catheterizing a patient. You don't want to put a lot of air in it. You just want to put just a little bit of air, enough for it to give it something to hold, to give the condom somewhere to stick to. Okay. So you hold this. Don't even know how to do this. So you will take your. By the way, I should have mentioned that this is a sterile procedure, because you're going to be putting this balloon catheter in the uterus of the patient. Okay. So you'll take your balloon, and then you'll insert the catheter to it. Okay. Past the balloon that you had inflated. Okay. Then you will have your assistant hold for you like this. Hold twice. The reason it is slippery, and you want to be able to tie it well. Okay. So while tying, you want to make sure that you tie tight enough for it not to loosen. Okay. But not so tight that you obstruct the lumen of the catheter. Okay. So the good thing is, the balloon also helps in holding the string in place. Okay. So helping you secure your catheter more. Okay, sawa. Doesn't have to be that tight, but tight enough not to come out. Sawa. So even if it's moving, the balloon will not let it come off. Okay. So once you have this set up, your assistant is still maintaining the pressure on the patient. Okay. So you'll put a speculum into the vaginal cavity of the patient. Remember, hopefully by the time he has put the pressure, the patient has stopped bleeding. True. Yeah. But still, the patient has been bleeding so much, so it's very slippery over there. So it takes some effort to put the condom tamponade inside. So you put a speculum, and then you will take a clamp. Hopefully a long one, because you know the uterus is deep inside there. Okay. You take a very long clamp. Make sure that when you're holding this condom catheter, you don't hold on this side of the string, because you might rupture the condom and make it ineffective, because we want to put water inside it. Okay. So you hold after the string. Okay. Okay, so you hold there, and then now you insert it into the patient. And you're trying to make sure that it goes inside the cervix and into the uterus. Okay, so make sure that you see it in the cervical os going in and disappear all the way in to the uterus, such that all you have left is the catheter. All that is inside the cervical os. Okay, once you have that, what you do is you need to fill it with water so that it can tamponade. It can tamponade the uterus. So normally, anywhere that is bleeding, if you put pressure on it, it stops. Okay, that's the same principle over here. So you're filling the uterus with water. Let's say this is the uterus. Okay, if I fill it with water, it is so full that there's nowhere to bleed into. Okay, so that's the whole principle of this. So you want to fill it and stop the bleeding. So at that time, you can start filling, and your assistant can stop compressing so that you can see if it's still bleeding, and then you start filling it. So there are two ways. You can use such a syringe if you have it. Okay, this is very easy because it's very big, and you can draw up your water so fast. Okay, so you start filling it like so. We'll get there. Let me. I'll remember to answer that question. So you fill it. You keep filling it. That's one way to have a syringe as such. But if you don't have, we all have giving sets. Okay. So what you do is you push your giving set inside here, all the way until it's tightly pushed into the catheter. And this time, I'm using the outlet, not the inlet. Okay. Sawa. And then you put your saline, and because it won't flow naturally, so you have to use your squeezing motion for this fluid. Okay. So we are putting fluid. How much do we put? You put as much fluid as is required until the balloon bulges out of the cervix. Okay. Why we don't say an amount is because it depends on the level of contraction of the uterus. If one patient uterus was this boggy, you'll need more fluid. Okay. If the other one was like this, you'll need less fluid. Okay. So I've heard of instances where it has gone even up to 1,000 mils. Okay. And some instances where 50 mils has been enough. Okay. So first of all, what will show you that you have achieved the tamponade is the balloon will bulge out of the cervix, meaning it has filled the uterus and the cervix, and it's now bulging. Okay. The other thing is the bleeding will stop. Okay. Because you have a tamponade, the bleeding should stop. Okay. So sometimes it's possible that you get some blood because maybe your condom is broken anywhere. And but it will be very dilute blood because it will be having the water. If it's a leakage, it will be different. You know how different it will be because of the dilute blood is different from the one that is actively bleeding. Okay, so we have put the balloon tamponade. You can keep it for a whole day, but this is not a treatment for PPH. This is a temporary measure to stop the bleeding until you can get definitive management. That is, call your obstetrician, call your theater team, prepare on the way forward for the patient. Okay. If you are in a peripheral facility, you want to refer the patient, refer this patient with the UBT in situ. Okay. Just note the amount of fluid that you have put in your patient. Okay. If you put 60 mils or 100 mils, note that I have put 100 mils, and then they can go remove the UBT at the center where they are actually giving the definitive treatment. Okay. So we want people to use this instead of packing with gauze, because once you pack with gauze starts soaking the blood. You can't see the bleeding, but the gauze is soaking the blood, so the patient is still bleeding. True? Yeah. Yeah. So in short, you're just putting your head under the sun, saying that because I can't see the bleeding, the patient is okay. The patient is not okay. They're still bleeding. Huh? So instead of using the gauze, put the catheter. Whether you are in a facility where the condom tamponade, where there is a theater, as you wait, normally. The theater preparation does not take a short time. True. And sometimes the people that you need to assist in doing all this management are not there. Okay. So as you wait, do the UBT. Okay. I want to cut it short so that you can practice. Okay. Yeah. Give me another catheter. A few people who want to practice how to do it as we ask questions. Any questions? Oh, I forgot. Once you're done, so that this water does not come out, you clamp here with a cord clamp. Okay. Yeah.
The question is, should you use warm saline water or just cold?
Ooh. I hadn't thought of that.
Warm will make the patient bleed.
Yeah. Yeah, I think cold. I had never thought of that. I have always used cold. Yeah, true.
When I came in, I saw people pulling the condom. We used to use water, we used to control the first.
Okay, just the first one it's very small. It's just for holding the nene. So you can use air also. Usually you use 3 mils or 5 mils maximum. So it doesn't matter what you use. Yeah.
So you can try.
Yes, please. Get your hands dirty over here. Okay, you'll have to open there.
Distilled water as well, or it's just normal saline?
You want to keep opening those 2 tubes?
Still like distilled water, you know, like the way they come in.
It's okay.
It's just normal saline.
It doesn't have to be just whatever you have, as long as it's sterile fluid. Remember, we're in the uterus. Yes. Wait, let's have some order. Who is trying? And who else?
We are assistants.
Oh, okay. Go to that side for ease of the. Sindio.
Yes, I'll give you. Oh, sound. Yes,
Okay, and then talk to us. Tell us what you're doing.
Explain. Having a patient with PPH, we have done all the maneuvers, but since our patient is bleeding, so we have opted for UBT as a temporary measure to control the bleeding as we refer our patient to the referral hospital.
Okay.
So here with me, I'm having my assistant. I've already ballooned my catheter around 3 to 5 mils. Just to anchor it on the condom. So you open for me? Fine. Get the string. Hold it for me. Try to fix it in the condom catheter. That level, and you can try to hold it for me and secure it.
Here's the string.
So, what is it? So, just use that one. Or you can secure. So, just secure it.
Not too tight.
Yeah, not too tight to.
Not too loose also.
And also not too loose, just firmly. Yeah, this is like gel. That's fine.
That's it.
Inatoka.
Double knot.
You can double knot. You can double knot it.
I think it is possible.
Yes.
If you don't tie it well,
Yeah, itatoka.
so you have to ensure that
So secure it well.
That's fine now.
That's fine, eh? Yeah, so you can be preparing your water, but after this, my assistant was applying pressure on the uterus. Then next up, I'm doing my speculum so that I can be able to insert this using my Kelly forceps. Put it up and with my string so that I don't really cause more harm. Okay.
You can cut the strings if they are disturbing you.
Yeah,
They don't have to be long.
fine. So I've inserted my speculum. Then I go to the cervix. Okay? I make sure I insert the catheter into the cervix, to the uterus. Yeah, so it is in.
Yes.
Yeah, so I balloon.
Just water.
Or water. Maji. Hapa.
Yes, that one.
Outlet. Draw. You can also use the giving set, but now if you're using the giving set, try squeeze manually. So just feel until you have enough pressure to the uterus. At that time, my assistant will have removed the hand from the uterus. So you feel based on the size of the uterus, right? And then now you can you feel until the condom is bulging
From the cervix.
from the cervix. Yes. So by that now we can be able to transfer our patient.
We reassess if the
Yes.
We reassess if the bleeding are stopped as we now prepare to transfer our patient to the county referral hospital.
Yeah. Ah, good.
We clamp.
Sorry, we forgot to clamp.
We forgot to clamp. Forgot to clamp. You clamp yet?
Yeah.
Fine. Thank you.
To prevent backflow.
Yes. Good.
Oh, you can also use this one, eh?
Yeah.
that is why we. Okay.
Perfect.
Thank you so much. So Nini, the cord clamp is easier for the lady to carry than this. Imagine this hanging under your
The
face.
clamp is just better.
Yeah.
But at least we have learned about the use of the Kelly to access the cervix.
Yes.
Tambo tulikuwa tukiumia sana, just go with your,
Your finger, it will keep sliding out.
It was so this is a bit efficient. Just go in.
Yes.
And these things, you will find them even at the dispensary.
Yes.
A question. Can you use the way people spigot the catheter with a 2cc syringe? This like a spigot. Can you spigot?
What is spigot? Abu explain to me. Maybe I'll get.
This part, the way it has.
Oh yeah.
You use
Instead of clamping, you put the
spigot.
yes, as long as it stops the backflow. Yes, it does. It does work.
Vomit, the last thing you can stand for.
Treatment. Yeah, now you go to the definitive treatment. Yeah. Sawa. We are done. Good. Thank you.